Hi everyone. I thought we wrapped up LipidCurious Season 1 pretty neatly. We spoke about lipids, triglycerides, fatty acids, cholesterol, lipoproteins, lipid pathways, ApoB, lipoprotein little, and even the birth of an atherosclerotic plaque. It felt like one big lipid family reunion, and everyone showed up. And then I remembered we did barely touched one of the most overused and underexplained concepts in medicine: inflammation. Inflammation is one of those ideas I thought I understood in med school, assumed I still remembered. We use the word all day in clinic, we blame it for half of the problems in medicine. But the moment I asked myself, if someone forced me to explain inflammation in one sentence, could I actually do it? I had to pause. So today, we are fixing that with a clear short note on inflammation. Welcome to Lipid Curious, the podcast dedicated to simplifying lipids for clinicians. I'm your host, Dr. Vishnupriya Pulipati, a board-certified endocrinologist and lipidologist. This is Season 1, Episode 10, Inflammation. Here's what we'll cover today. 1. What is inflammation? 2. How do we measure it? 3. How do we treat it? And finally, a heartfelt wrap-up of Season 1. If you're new here, welcome. This season builds step by step, so you might want to start with Episode 1 to get the full picture. You'll find the bonus visual handouts for every episode, plus a free starter kit at www.lipidcurious.com. And as always, this podcast is for educational purposes only, not medical advice. All right, let's dive in. What is inflammation? Inflammation is the body's built-in emergency response to an injury, infection, or irritation. The 5 classical signs of inflammation are redness, warmth, swelling, pain, and loss of function. Here's the play-by-play. After an insult, such as an injury, cells release chemical messengers like histamine and prostaglandins. Blood vessels widen, so more blood flows, which leads to redness and warmth. The vessels start getting leaky. The immune cells rush into the tissue, and this causes swelling and pain. The pain is partly mechanical and partly a protective signal. It's your body's way of saying, hey, don't mess with this place, we are trying to fix it here. The immune cells which get into the tissue start cleaning up the debris, fight the pathogen, and starts the repairs. This entire inflammation process is normal, essential, and adaptive. Without inflammation, wounds wouldn't heal. Even a paper cut could be life-threatening. But, and here's the catch, inflammation is helpful only when it is short-lived and targeted. Now, there's no perfect cutoff for what's considered acute versus chronic. But, in general, acute inflammation is sharp and focused, resolving within 1 month. Chronic inflammation is slow, quiet, and persistent, lasts more than 3 months up to many years. Chronic inflammation shows up with metabolic dysfunction, autoimmune conditions, poor sleep, nicotine use, obesity, stress, chronic infections, and sometimes we don't even feel it. This chronic low-grade background inflammation is the kind that directly ties to cardiovascular diseases. And here's the key connection. If ApoB-containing particles are the spark, inflammation is the fuel that keeps the fire burning. You need both of these for atherosclerosis to grow, progress, and rupture. Inflammation worsens endothelial dysfunction, pulls the immune cells into the arterial wall, promotes foam cell formation, drives oxidative stress, and expands the necrotic core. Inflammation is not a side character, it's in every scene of plaque development. Next, how do we measure inflammation? In real-world practice, one biomarker stands far above the rest: HSCRP, or high-sensitivity C-reactive protein. It's quick, it's cheap, it's widely available, and it predicts cardiovascular risk as strongly as blood pressure or cholesterol. Here's how we interpret it. Less than 1 milligram per liter, lower risk. 1 to 3 milligram per liter, average risk. More than 3 milligram per liter, higher relative risk for cardiovascular disease. More than 10 milligram per liter, think infection. Repeat it again in 2 to 3 weeks. Other biomarkers do exist, such as serum amyloid A, interleukin 6, fibrinogen, white blood cell count, neutrophil to lymphocyte ratio, lipoprotein-associated phospholipase A2, myeloperoxidase, eicosapentaenoic acid by arachidonic acid ratio. I know these are all new terms to me as well, but none of them beat HSCRP in terms of practicality or regulatory recognition. And clinicians, as you know, don't act on numbers they never check, which is why universal HSCRP screening is recommended in both primary and secondary prevention, as long as the patient isn't acutely ill. Imaging? Yes. CT, MRI, ultrasound, and PET scan with FDG can visualize vascular inflammation in research, but they're not routinely used in clinical practice to identify inflammation. How do we treat inflammation? There are 3 main treatments for inflammation. Hear me out. Lifestyle, lifestyle, and lifestyle. And it works. Mediterranean or DASH diet, plenty of fruits, vegetables, whole grains, legumes, nuts, and olive oil. Omega-3s, aim for 2 to 3 servings of fatty fish per week. They're all helpful. Minimize red processed meat, sugary drinks, and refined carbs. Regular exercise, up to 150 minutes of moderate exercise or 75 minutes of vigorous exercise per week. Nicotine avoidance and maintaining a healthy weight are all helpful in improving lifestyle and combating inflammation. Medications, we currently have 2 options available. 1. Statins. They lower LDL-C and inflammation. In primary prevention, a persistently elevated HSCRP, especially more than 3, is a reason to consider initiating or intensifying statin therapy regardless of LDL. In patients already on statins, but HSCRP is still more than 2 mg per liter, you can consider higher intensity statin, regardless of LDL. 2. Low-dose colchicine is now FDA approved for reducing CV events in stable ASCVD patients. It is an adjunct to lipid-lowering therapy. It is not a replacement to it. This was found not to be very helpful in situations of acute ischemia, and you want to avoid colchicine in patients with significant renal or liver dysfunction. So inflammation is no longer just a background character. It is now a modifiable risk factor. These are the 3 take-home points for inflammation. 1. Chronic low-grade inflammation is directly tied to cardiovascular disease. You need both ApoB particles and inflammation for atherosclerotic plaque to grow, progress, and rupture. 2. HSCRP is the most practical inflammatory marker we have. Use it. 3. Lifestyle is your strongest anti-inflammatory prescription. Other options include statins and low-dose colchicine. All right, folks, if you have been here with me since episode 1, thank you. Your curiosity is what made this season come alive. You showed up for 10 episodes of pathways, particles, metabolisms, and biology, and you stayed engaged through all of it. When I started LipidCurious, I didn't have a grand plan, a strategy, or even a budget. We already have incredible resources that break down trials, guidelines, and therapies. I just felt something was missing in our usual lipid conversations, a bridge back to the foundations. This project started from a space of inspiration and abundance. By supporting this project, you showed that clinicians want clarity, that foundation matters, and that lipid science can actually feel exciting when it's understood in a way that makes sense. Along the way, many of you reached out to me with questions, insights, and encouragement. That feedback shaped this season more than you know. Your messages reminded me that this effort mattered and that there was a need for this kind of a conversation. Of course, I had moments where I wondered, why am I doing this and for whom? But LipidCurious platform gave me the confidence, a creative outlet, and a deeper connection to a field I love. I learned and unlearned so much along the way. And every time I reached out to a mentor with a question, they responded with such contagious enthusiasm. That energy reminded me why curiosity matters. And somewhere between episode 1 and episode 10, it became clear that Lipid Curious isn't just about lipids. It's about prevention, lifespan, and the quiet power of small changes. It is the power to give our patients many more years of good quality of life to spend with their loved ones. So what's next? Well, Season 1 will be available until May 2026 while we take a thoughtful pause. The future of Lipid Curious depends on time, resources, and where this community wants to go. And your input matters here more than ever. If this platform has supported your learning and you would like to see it grow, whether through collaboration, sharing it with colleagues, or small contributions, you're always welcome to reach out. If you have ideas for episodes, partnerships with societies, or creative ways to expand this mission, I'm listening. You can always reach me at hello@lipidcurious.com. And don't forget to grab the free starter kit and the Season 1 visual guide at www.lipidcurious.com. To the mentors, colleagues, and every listener who believed that curiosity deserves space, thank you. This has been one of the most meaningful projects of my career, and it's because of you. Whether this is a pause or a beginning of something new, thank you for being a part of the Lipid Curious community. Until next time, stay curious and stay confident. Signing off, Dr. Pulipati.